Ladies and gentlemen, good morning, good afternoon, good evening. Thank you for joining the International Federation of Fertility Societies for this IFFS webinar series, which is now a monthly presence, delivering education for REI practitioners. This particular series is on progesterone use in reproduction, and this particular talk is on luteal phase in ART therapy, particularly the protocols. We have the pleasure of having today Professor Elena Labarta. Professor Labarta works in EV-RMA. She is an MD, PhD. She studied medicine from University of Saragossa, and then she completed her residency in obstetrics and gynecology in Madrid, followed by a training in reproductive medicine in EV Valencia. She has been involved for many years in very large research projects, and she obtained her PhD doctor cum laude from University of Valencia in 2014. She's a teacher, she's a supervisor of master's degrees, and we're truly delighted to have Professor Labarta today discussing practical aspects of how we use progesterone in practice and what do we monitor. So Professor Labarta, thank you for your presence, and we look forward to your presentation.
Thank you very much, Edgar. Thank you everyone for being here today. It is my great pleasure talking in this setting and talking about progesterone, that has been the topic of my research in the last year. So in the next slides, I will share with you all the investigations that we have been conducting. Most of the things, perhaps you know them already. We will show new things, but I hope that it will be very useful for you in the management of luteal phase support. Let me share my screen. Fantastic. Okay. So I'm going to talk about the luteal phase support and management in ART, in the different protocols that we are using nowadays to transfer the embryo. As many of you know, well, and as all of you know, progesterone is so important in reproduction, not only during the first stages, because it helps into the embryo implantation and placentation, but also it has a very important immunological effects, helping into the maternal immunotolerance. And this is why it is so important to give the patient, mainly the infertile patient who is under an infertility treatment, an adequate dose of progesterone. But to do so, we have to take into account in which scenario we are transferring the embryo, because we can be doing frozen embryo transfer in a natural cycle, in an stimulated cycle when it is a fresh IVF cycle, for example, or in an artificial cycle. And depending on these scenarios, the needing of exogenous progesterone will be completely different, being low or not necessary in some natural cycles, and being much higher in the artificial cycle. Why? Because of the lack of a corpus luteum producing endogenous progesterone. So in this scenario, which is the one that we have studied more intensively, it is more important to give adequate doses of exogenous progesterone because the patient is not producing endogenous one. In the stimulated cycle, as you can see, there are several corpora lutea producing endogenous progesterone, but we have to compensate the the high levels of estradiol that are present after the oocyte pickup, and the luteolase is present after this procedure. So this is why usually, as I will explain you later, in stimulated cycles, we recommend the luteal phase support. There are different routes of progesterone administration. Classically, very frequently use the vaginal route, but also we have the option of using the rectal route, intramuscular, subcutaneous routes. All these routes are used when we are using natural-like progesterone, that is a progesterone which molecule is completely similar to the one produced endogenous. But we have also the option of using the oral route. Oral route can be used with natural-like progesterone, but because of the low viability, we usually reserve the oral route for the synthetic progesterone, that is the so-called dydrogesterone. Until now, in most of the centers, or many doctors choose the vaginal route for as the best route for luteal phase support, followed by intramuscular and subcutaneous. But it is true that perhaps this distribution could be a slightly different nowadays, after seeing that some patients are infra-treated when using vaginal progesterone. But well, as I will explain you later, the key point here is to do an individualized luteal phase support. But this is the distribution so far in the route of progesterone given in our patients. The differences among the different routes of progesterone are mainly because they are completely different in terms of pharmacokinetics and pharmacodynamics. We cannot compare the behavior of progesterone, serum progesterone, when using vaginal or rectal progesterone that are absorbed very well in this scenario, and you reach quite steady levels of progesterone when given this route. On the contrary, the oral micronized progesterone is not absorbed so well. It has some advantages, but usually the plasma levels are low and not enough for doing an adequate luteal phase support. On the contrary, when using intramuscular or subcutaneous progesterone, we see high levels of serum progesterone after the injection, but after this peak, we observe also a decrease. So when interpreting the serum progesterone levels, we have to take into account the different pharmacokinetics according to the route of progesterone. And then we have obviously the option of the dydrogesterone, the oral dydrogesterone, that is the synthetic progesterone. And we have to take into account that obviously it is a very good alternative for luteal phase support, but we cannot monitor the luteal phase so easily, because this molecule cannot be measured in blood with the traditional assays to measure progesterone, because this molecule is not measurable in a regular laboratory. And here you can see the proposed doses of progesterone according to the use of natural-like progesterone or synthetic progesterone, and according to the route of progesterone given, and finally according to the type of cycle in which we are transferring the embryo, either natural, stimulated, or artificial. This is a table that I have created for you, but obviously the final doses are chosen based on doctors and clinics' preference. And the thing is that there is no ideal dose for all patients. And the ideal situation would be to do a monitorization of the luteal phase to see which is the best dose for each individual patient. And to do so, the ideal situation would be to measure serum progesterone to see if the patient is absorbing adequately progesterone, and to see if the patient need to increase or decrease the dose of exogenous progesterone. The thing is that for many years we were not looking at serum progesterone levels because we thought that they were not reflecting the effect in the uterus. Why? Because traditional or all studies had demonstrated previously that there was a completely different pharmacokinetic dynamics, for example, when comparing intramuscular versus vaginal. And for example, when using intramuscular progesterone, you observe much higher serum progesterone levels in comparison with the use of vaginal progesterone. But on the contrary, when going to the uterus, you saw that uterine levels of progesterone were much higher with vaginal progesterone. So this is why we said it makes no sense to measure serum progesterone levels, because at the end, the important thing is to have high levels in the uterus, and this is reached with vaginal progesterone. And these high levels observed in the uterus were explained because of the well-defined first uterine pulse effect. That means that after the insertion of vaginal progesterone, there is a rapid absorption by the uterus, and if you measure the levels at that moment, you see very, very high levels. On the other side, serum progesterone levels were not measured also because it was demonstrated previously that there is a huge variation of serum progesterone levels throughout the day, mainly in natural cycles. You can see that in one whole day, you can see very different results of serum progesterone levels because of the pulsatile production by the corpus luteum. In the stimulated cycle, it happens more or less the same, mainly in those patients with high levels of progesterone. And this makes things very difficult because depending on the moment in which you are measuring progesterone, you will observe different results. In the artificial cycle and when using vaginal progesterone, it has been seen that the levels are much more constant and more reliable. We have to accept, and this has been demonstrated, that there is a slight variation throughout the day according to the moment in which you are measuring progesterone, but it's not so significant as when compared with the natural unstimulated cycle. So if we have to measure serum progesterone levels, the artificial cycle is the best scenario. So let's start talking about artificial cycle and luteal phase support and management. Is there a scenario in which we have done more research, because until some years ago, this scenario, this protocol was very frequently used for doing frozen embryo transfer cycles because of logistics and facility. But at the end, we have learned a lot about the management of artificial cycles. We have learned about the advantages of using natural cycles. And well, I think it is important to bear in mind all the advantages and disadvantages of artificial cycle when choosing the protocol for doing frozen embryo transfer cycle. As I said before, artificial cycle is the best scenario to evaluate the impact of exogenous progesterone supplementation. On one hand, because the measurable serum progesterone comes only for the exogenous supplementation, so we are evaluating the net effect of the exogenous one, and on the other, because we reach stable plasma concentrations with this assumed variability, but much more easy than the ones observed in natural cycles. And the most important message is that since year 2015, 2016, many studies have arisen to demonstrate that serum progesterone levels impact the ongoing pregnancy and live birth rates. And there is a minimum level of serum progesterone that needs to be reached to optimize the outcome. This message, I think that nowadays is very well assumed, but some years ago it wasn't, because we thought that levels of progesterone were not relevant. But among all these studies, the two prospective ones, the ones that we have conducted in our study, demonstrated clearly the big impact of having low serum progesterone levels. Our first study was conducted in egg donation cycles in a small sample of 211 patients, and we measured the serum progesterone levels the day of embryo transfer. We didn't see the results, we didn't manipulate the luteal feed support, and then when the study was finished, we correlated the serum progesterone levels with the ongoing pregnancy rate. And our surprise was that we saw that those patients having serum progesterone below 9.2 nanograms per ml, which was the percentile 25th, had 20% lower ongoing pregnancy rate. And this was very, very significant. This is why we decided to do our second prospective study, blinded study, including a big sample, 1150 patients with no so many restriction criteria, just to see if these results were applicable in our regular daily practice with all our patients using own eggs, donated eggs. And once again, we observed the same results. We observed that those patients having low serum progesterone levels the day of embryo transfer showed 18% lower ongoing pregnancy rate and 17% lower live birth rate. Thanks to this big sample size, we were able to define very nicely the critical cutoff of serum progesterone that was located on the percentile 30, corresponding to a level of progesterone of 8.8 nanograms per ml. You can see that those patients having serum progesterone levels between 9 and 10 had pretty good results. And I say this because in many groups they are like putting the critical cutoff in 10 to make it more simple. That's okay, but at the end, this study demonstrated that the critical point is around 9 nanograms per ml in artificial cycles, just to let you know. The next question was why these patients are having worse results, why having low serum progesterone levels decrease ongoing pregnancy rates. Our question was if it was because of a decrease in endometrial receptivity or other reason, other extrapelvic effects of progesterone. So to answer this question, we wanted to analyze if there was any correlation between serum progesterone levels in the mid-luteal phase and the endometrial receptivity test that at that moment was the ERA test, the one that was available for analyzing this. And also, we analyzed if there was a correlation with the uterine progesterone levels. And as you can see here, we could see that serum progesterone that was so relevant and so important for our pregnancy rates was not related either with the ERA test or the endometrial receptivity test nor with the endometrial progesterone and endometrial 17-hydroxyprogesterone. And on the contrary, the hormonal levels present in the uterus were related to the erecteds. In fact, those patients having high levels of progesterone in the uterus showed a receptive erecteds in 71% of the cases, whereas those patients with low levels in the uterus of progesterone and 17-hydroxyprogesterone showed only 13% of receptive erecteds. So at the end, to make it simple, we have seen that uterine progesterone is important, but for receptivity acquisition. So there is a minimum level of progesterone that needs to be reached in the uterus to become the uterus receptive and to favor embryo implantation. But the other story is the impact of serum progesterone, that progesterone that is in the bloodstream, and these extra pelvic effects of progesterone are the ones that help into the pregnancy maintenance, probably because the progesterone has a role not only on implantation, that is the first part of the story, but most importantly on the immunomodulation and placentation during pregnancy. And there is a huge body of evidence to support this. So if I have to choose measuring uterine or serum progesterone levels, obviously I choose serum progesterone levels because are the ones clearly related to the pregnancy rates. We observed systematically after so many studies that 3 out of 10 women showed inadequate levels of serum progesterone when using the same dose of micronized vaginal progesterone in HRT cycles. All of them are receiving the same dose, but in the different studies that we had been conducted, we saw always a similar prevalence of low serum progesterone levels. And the question was why? Which are the risk factors to have low levels of progesterone? Different studies have been conducted to answer this. Some have been published by other groups, but all of us agree that body mass index impacts on serum progesterone levels, as I will show you later. Also, it was published that patients who are active smokers or with background of previous vaginal deliveries, non-European origin, mainly black race. Also, we have seen that there is an impact of using capsules versus pessaries on the levels of progesterone. The root of progesterone, as I explained you before, it's also important on the levels of serum progesterone levels and on the moment in which you are analyzing this level. The time of blood sampling is important, as I told you before. If the time frame between the last insertion of progesterone and the measurement influence on the result, although it is not clinically relevant, and the background of having a previous cycle in which the levels of progesterone were low. So this will increase the risk of having once again low serum progesterone levels. Why? Because probably there are some intrinsic factors related to the patient that increase the risk of having low levels. And among all these factors, we have analyzed the impact of vaginal dysbiosis on the absorption of progesterone, and we have seen interesting results, as you will see now. Regarding the BMI, you can see here how, according to our database, we see that in overweight and obese patients, the percentage of low progesterone the day of embryo transfer is even higher than 30% or 25%. In obese patients, it could be 44%. So this means that if you are facing a patient with obesity or overweight, perhaps you should give more progesterone from the beginning, because for the risk of having low levels of progesterone with the regular doses is going to be higher. And this has been refuted by other groups. And regarding the impact of vaginal microbiome, this is something very new. We will send these results this year to Israel, and we have seen that those patients with lactobacilli dominant microbiome in the vagina, not in the uterus, we are talking about vagina, showed a significantly higher levels of progesterone in comparison with those patients with dysbiosis. And in fact, the percentage of patients having low serum progesterone levels on the mid-luteal phase was 5.4, which is considered low according to our statistics in patients with normal microbiome, whereas in patients with dysbiosis, the percentage increases up to 21%. So this is something really interesting that needs to be further explored, but perhaps this can explain why the vaginal absorption of progesterone is different among patients. Which is the ideal dose of progesterone or vaginal progesterone in artificial cycles? Well, it has been stated that probably the ideal dose would be 400 every 12 hours. Why? Because on one hand, gives you the best endometrial secretory transformation based on Noyes criteria. And on the other, you can see how with this dose, you reach the highest serum progesterone levels. Being in the safe window, but being aware of the importance of having high levels of progesterone, I think that it is convenient to give this dose to ensure good absorption. In fact, in this study in which the authors compare 600 versus 800 of vaginal progesterone, they saw that with 800 milligrams per day, the mean level of progesterone was significantly higher, and the ongoing pregnancy rate was also higher. So the recommendation is to be given 800 milligrams per day. When should we measure serum progesterone during the luteal phase? Well, obviously, we have seen that the day of embryo transfer, it is the ideal moment, or one day before. Why? Because it's been related to success rates on one hand, and on the other, and as I will explain you later, it is an opportunity to perform an individual luteal phase support and rescue the pregnancy rates. And what about the serum progesterone levels during the late luteal phase? Because we have been focused on the day or the moment of embryo transfer, but what happens later? Well, we did a study in which we measured serum progesterone levels 4 days, 7 days, and 11 days after embryo transfer. And we compared the results of progesterone according to the final evolution. We saw, interestingly, that in patients who ended up with an ongoing pregnancy, the levels of progesterone were increased throughout the mid-late luteal phase, whereas in patients with a negative result, the levels of progesterone maintained constantly much lower, significantly lower. And this means that probably at this moment, the day of the beta HCG, it could be late to measure serum progesterone levels, and we should measure serum progesterone levels before, on the moment of embryo transfer. It is true that at the moment of the beta HCG, if the progesterone is low, it seems that the addition of more progesterone can prevent from miscarriage. This has been demonstrated by another group, but we should prevent from this from the beginning, from the moment of embryo transfer. And what to do when serum progesterone levels are low? Well, I defend always individualization. I defend to measure progesterone to see if the patient needs an extra dose of progesterone. And this is what we did in a study that I'm going to show you now, the study in which we decided to add an individualized luteal phase support and a rescue treatment with subcutaneous progesterone from the day of embryo transfer onwards in those patients with low levels of progesterone the day of embryo transfer, in those patients having serum progesterone levels below 9.2 nanograms per ml. And we compare these results with those patients with good progesterone levels from the beginning. And you can see here that there were no longer differences in the positive beta HCG, in the clinical pregnancy, clinical miscarriage, ongoing, or live birth rates. What does this mean? This means that if we do the rescue treatment since the day of embryo transfer, we can save the situation. Nowadays, patients are really scared about the possibility of having low levels of progesterone the day of embryo transfer because they have read in the internet about the impact of having low levels. But we should be aware of this. We should know and tell the patients that if we detect the problem the day of embryo transfer and we rescue with more progesterone, the results are absolutely comparable. And this is very important and very convenient for clinics because it is not necessary to measure progesterone before, which is logistically complicated sometimes. The rescue treatment can be done also with rectal progesterone. In fact, the group of Alsberg have compared the results in patients having serum progesterone levels below 11 nanograms per ml. They choose that cutoff, who were rescued with rectal progesterone since the day of embryo transfer. And they compare the results with those patients having adequate levels with only vaginal progesterone. Sample size is not very huge, but enough to see differences, and they didn't see any difference in the pregnancy loss rate and the ongoing pregnancy rate. So once again, this means that the rescue treatment is effective even with the use of rectal progesterone. And this is probably because that patient who is not absorbing well vaginal progesterone has a reason for that, and probably it's some vaginal condition. So perhaps the best alternative is to look for another routes of progesterone administration and not increasing the dose of vaginal progesterone because there is a limit in the absorption of vaginal progesterone. And finally, some authors have also analyzed the impact of rescue treatment in artificial cycles with dydrogesterone, the synthetic progesterone given orally. So they did the same analysis. They compare the results in patients who had serum progesterone levels below 8.8 nanograms per ml following our cutoff, thank you. And in those patients, they added dydrogesterone, and they compare the results with those patients having adequate levels from the beginning. They haven't seen a difference in liver rates. So no matter if the serum progesterone levels are low the day of embryo transfer, if you detect the problem and you do a rescue treatment, either with subcutaneous, with rectal dydrogesterone, or obviously IM, the idea is to add another route of progesterone administration, you will save the pregnancy rates. So having said this, I would like to point out the importance of tailoring treatment to a single patient, because there is one option that is the ordinary treatment to all patients. You don't measure serum progesterone levels because of logistics or whatever, and you treat all patients with rescue treatment or with very high doses. But I have to say that perhaps too much progesterone could be detrimental, and this obviously will increase the cost and the burden of the patient. And the ideal situation would be to do a personalized treatment in which you measure serum progesterone levels, you detect which patients are infratreated or are not absorbing adequately the vaginal progesterone, for example, or other routes, and you do the rescue treatment only in those patients, because it has been demonstrated that it is effective and you are not over-treating patients. So after this long explanation about the artificial cycle, I would like to do a summary for you of the luteal phase support research in artificial cycles in our center and in other groups. First, and most importantly, we were able to detect a problem. We detected that a critical cutoff of mid-luteal serum progesterone levels was present around 9 nanograms per ml, and ongoing pregnancy rates decreased significantly below this threshold. The prevalence is between 20 and 30%. Nowadays, I would say that is moving to 20%, because I think that we are more aware of the strict administration of vaginal progesterone. Many years ago, we told the patients, okay, you can insert vaginal progesterone in the morning, at night, no matter the moment. And nowadays we are like more strict on the timing. And thanks to this, we have decreased a little bit the percentage of patients with low progesterone levels. We have been able to detect the risk factors that can increase the risk of having low serum progesterone levels. And finally, we have found a solution, that is the individualization in those patients with low levels of progesterone. We do a rescue therapy. So it's been a very nice story, beautiful. And we have learned a lot about this, because obviously we can rescue the situation, but at the end we are aware that we are giving perhaps too much hormones to the patient. So perhaps it's a moment to consider the option of doing more natural cycles, mainly at this moment in which we are aware of the risk of preeclampsia and other alterations during pregnancy. What about luteal phase support and progesterone levels in the natural cycle? As I said before, the difficulty relies on the fact that there is a huge variation throughout the day. The thing is that we know for many years which is the minimum level of progesterone that should be reached in the mid-luteal phase. Luteal phase deficiency was described as having serum progesterone levels below 10 nanograms per ml in the mid-luteal phase, but well, it is assumed that there is a big difficulty to define a luteal phase deficiency. But in our setting, in patients undergoing embryo transfer in natural cycles, we know that at least this level of progesterone should be reached, as I will show you later. We have two options for doing the transfer in a natural cycle. The pure natural cycle is without any medication, no trigger of ovulation, only based on LH surge, and no additional, no exogenous progesterone given. The modified natural cycle, it is a very nice option to move to more or to switch from artificial to natural, but being able to control or to program the day of embryo transfer more easily. It consists on giving yes or no the ACG injection for trigger ovulation and the use or not of luteal phase support. What happens in the pure natural cycle without ACE and without progesterone administration? Well, in this nice retrospective study, the group of the Exeus compare the results in patients according to having serum progesterone levels the day before the embryo transfer below or above 10 nanograms per ml. And as you can see in the graph, those patients having serum progesterone below 10 nanograms per ml had a significantly lower pregnancy rate and a significantly lower live birth rate. And most interestingly, for me, one important message of this study is that 1 out of 3 patients, infertile patients undergoing a pure natural cycle, showed a serum progesterone level below 10 nanograms per ml. And this is in accordance with other publications, for example, this one in JCM, in which when you are analyzing the risk of having luteal phase deficiency in pure natural cycles, you see that it is higher than previously thought. And this can explain why, for example, in this randomized control trial, the results in pregnancy rates were significantly better in those patients with a modified natural cycle in which they administered exogenous progesterone after spontaneous ovulation. So why? Because probably you are covering those patients with a luteal phase insufficiency. Perhaps it's not necessary to treat all of them, but perhaps it should be convenient if you are in a pure natural cycle to measure progesterone to see if this patient is producing adequate levels, and if not, you add exogenous progesterone. The difficulty here is the measurement of serum progesterone in natural cycles, as I said before. In our center, we do many natural cycles, but modified natural cycles with the use of ACG for triggering ovulation and the addition of exogenous progesterone at a dose of 200 milligrams every 12 hours. And we wanted to do the same study as the one that we did in artificial cycles. We decided to measure serum progesterone levels the day of embryo transfer, not seeing the results, not manipulating the luteal phase support, and see what happened in order to evaluate the impact of serum progesterone levels on the outcome. The first interesting finding that we observed in comparison with our previous studies in artificial cycles was that the mean serum progesterone levels observed on the day of embryo transfer in these modified natural cycles was 26 nanograms per ml in comparison with 12 nanograms per ml observed in artificial cycles, even though in artificial cycles we were using double the dose. We were using 800 milligrams per day versus 400 in modified natural cycles. And then when we decided to, we saw only 2 patients with serum progesterone levels below 10 nanograms per ml, which accounts for 0.8% of the population. So this means that when you give luteal phase support in natural cycles, you are covering almost 100% of the population, or giving them enough dose of progesterone to be on the safe side. When we divided the population in 4 groups according to the level of progesterone the day of embryo transfer, we didn't observe any negative impact of having low serum progesterone levels the day of embryo transfer on the ongoing. In fact, you can see that the first quartile had even better results, not statistically significant, obviously, but you cannot see a trend towards worse results in patients with low levels of progesterone. But why? Because this level of progesterone corresponding to the percentile 25th is not low. It's 20 nanograms per ml. That is more than enough for a natural cycle. So what we have learned from this study is that perhaps with 200 milligrams per day, it could be enough in natural cycles, in modified natural cycles, just to give us support to cover those patients with inadequate levels, but probably you don't need too much progesterone later on because you are not increasing your results. Well, individualization has been also tested in natural cycles. In fact, this study has analyzed serum progesterone levels in true natural cycles, in pure natural cycles, and they decided to add subcutaneous progesterone and individualization of the luteal phase support, as we call this, in those patients with serum progesterone below 10 nanograms per ml. And they compared the results to those patients having a good progesterone level from the beginning. Sample size was not so high, but they didn't see in this retrospective analysis, obviously sample size is very low for being retrospective, but they didn't see a difference in pregnancy outcome. But for me, the most important message here is that a high percentage of patients in a pure natural cycle showed serum progesterone levels below 10 nanograms per ml. So one option is to give a slow dose of progesterone to everyone. Another option is to measure progesterone the day of embryo transfer, and if it is low in a pure natural cycle, you can decide to give a support with more progesterone. And let's finish with the stimulated cycle. The stimulated cycle needs progesterone. According to this Cochrane review, it was demonstrated that can increase the luteal phase support in this scenario, can increase live birth rates, although the evidence level was low. No matter the route of progesterone administration, here in this review, they compared the different routes. Rectal was not significant because of a low sample size, but at the end, no matter which type of progesterone, and nowadays we know also that dydrogesterone is a very good option for luteal phase support in stimulated cycles, because compared to placebo, it will increase the chances of pregnancy. Why? Because in stimulated cycles, we know that luteal phase is always inadequate. In these cycles in which you trigger with ACG for a fresh embryo transfer, you see a huge increase of progesterone levels after the oocyte retrieval, but a huge decrease some days later, and much more rapidly in comparison with a normal or natural cycle. And in cycles in which you trigger ovulation with a generate analog instead of ACG, there is there seems to be an optimal window of serum progesterone levels at the moment of embryo transfer. So we wanted once again to see if serum progesterone levels were impacting ongoing pregnancy rate in stimulated cycles, and we did the same design as in artificial and natural cycles. We did a prospective blinded study in patients undergoing a fresh embryo transfer after an ACG trigger and with our regular luteal phase support with 200 milligrams every 12 hours. The first interesting finding was the mean serum progesterone levels that we observed. We saw 92 nanograms per ml on the day of embryo transfer in comparison to 12 nanograms per ml in artificial and 26 in natural. So we were very far from the physiological or natural levels of progesterone in the mid-luteal phase. And when going to the quartiles of serum progesterone, we didn't see any correlation of levels of progesterone and ongoing pregnancy rate. Probably because even in the case of having low levels of progesterone, they were very far from the critical cutoff, at least in our setting. And we are not stimulating harder than other groups. I mean, in our setting, using moderate doses of gonadotropins and ACG, we see that if you do this type of treatment and luteal phase support, patients are having very good levels of progesterone. Only 9 patients showed serum progesterone levels below 25 nanograms per ml, which was like the critical cutoff proposed previously, but it didn't have an impact on the ongoing pregnancy rate. So according to this, we can conclude that in our setting and using an ACG trigger and luteal phase support, it is not necessary to measure serum progesterone levels. We saw a correlation of the number of oocytes with the serum progesterone levels of the day of embryo transfer. Because we analyzed that, we expected to have this finding because the more follicles, the more corporal lutea producing progesterone, and the higher the level of serum progesterone levels. But when we did the logistic regression analysis, we saw that serum progesterone levels were not predictive or impacting the ongoing pregnancy rate, even after adjusting for any confounding factors, including the number of oocytes. So the message is clear. Another story is the impact of serum progesterone levels, not in the mid-luteal phase, but on the day of the beta ACG. In fact, it's been demonstrated that serum progesterone levels the day of the beta ACG are or have a high capability of prediction of success or ongoing pregnancy liver rates after the first trimester. And I would say that perhaps it is not important to measure serum progesterone in the mid-luteal phase, but later on in the late luteal phase, at the moment of the beta ICD determination, perhaps it should be convenient in those cases in which you are considering the option of stopping luteal phase support, because according to the results of this Melaset study, in which they maintained the luteal phase support until the day of the positive pregnancy test, they observed that those patients having a positive beta ICG test but a low level of progesterone miscarriage very frequently. And they concluded that perhaps the prolonged luteal phase support in this scenario could have rescued some pregnancy losses. So if you are considering to stop luteal phase support very early, perhaps it is convenient to measure serum progesterone levels to see if we should maintain exogenous progesterone a little bit longer. And with this extensive review of all the state of the art of luteal phase support in these 3 different scenarios, I would like to point out the most important take-home messages. As you have seen in the modified natural cycle in which you are using ACD and vaginal progesterone, you don't need to measure serum progesterone levels because only a very small, tiny percentage of patients show inadequate progesterone. On the contrary, in the pure natural and in artificial cycles, we have seen that you should measure serum progesterone levels because 20-30% of them will show inadequate progesterone, which in turn decreases pregnancy outcome. And in the stimulated cycle, if you are using luteal phase support and you have done an ACG trigger, according to our data, you don't need to measure serum progesterone levels because we haven't seen a clinical impact on that. So thank you very much for your attention. I am absolutely available for you for any question that can appear after this presentation. Thank you.
Professor Labarta, thank you so much for very comprehensive and beautifully summarized hour of scientific evidence from your own practice and also the review of the literature. At this moment in time, it is customary to spend 20-30 minutes discussing any questions that might arise. Just to be clear, the way to ask a question is to place it in the Q&A box, which is at the bottom of the screen. So the bottom of the screen to the right of the share screen button is the Q&A. Just click on it, type your question, and we'll be able to dialogue with Dr. Labarta. I would start with one question. In fact, there are 3 questions, but from one person in the audience. So one was, when do you measure the serum progesterone in general? Then, as the presentation evolved, the question was, in the artificial cycle, when do you measure it? And then, how do you increase the dose of progesterone, of course? Thank you.
Okay, thank you for your question. Well, we have the possibility of measuring serum progesterone the same day of embryo transfer because our laboratory is in the same clinic in which we do the embryo transfer. So we do this the day of embryo transfer. And usually we recommend to measure serum progesterone levels 6 hours plus minus 2 hours after the last insertion of progesterone, just to see, to avoid measuring progesterone immediately after the insertion of progesterone that can give you higher levels. And we are like quite constant on that, trying to be able to evaluate our results. If not possible, you can measure serum progesterone levels 1 or 2 days before, okay? Because after 1-2 days of progesterone administration, you will see steady levels. So if you don't have the possibility of having quick results, you can measure progesterone 1 or 2 days before. If you are giving rectal progesterone, the advice is the same according to the timing. If you are giving intramuscular or subcutaneous progesterone, I recommend you to wait minimum 6 hours after the injection, because if you measure progesterone immediately after the injection, you will see very high levels, you will be so happy, but if you measure 10 hours later, perhaps it will be critically low. So you have to be in the middle. And according to, we are doing a pharmacokinetic study comparing these different routes, and we see that a recommendation is to wait until 6 hours after the injection.
Thank you for that. There's one question that was typed in the chat, so I'll take that next, as I suggest we should not type the questions there, but it is a pertinent one. The question says, do you recommend the use of vaginal progesterone for endometrial preparation, so in before the transfer, and after the embryo transfer, use intramuscular or subcutaneous? In other words, switch from vaginal to intramuscular or subcutaneous?
Well, only when it is necessary. I mean, you choose a route and you can continue the same route if patient is being exposed to adequate levels. So obviously we have to respect the preferences of the patient and the doctor, of course, but sometimes the patient prefer to inject or to receive vaginal progesterone, but you have to continue with this protocol if the patient is absorbing well. The increase in or the addition of IM or subcutaneous, the diaphragm transfer, for the moment, as far as I know, has not been demonstrated to increase the ongoing pregnancy rates. Okay, because if the patient is absorbing adequately, no matter the route of progesterone given, why to give extra high doses of progesterone? So for the moment, I think that we should be very cautious because it is not yet demonstrated the real safety of giving supra physiological doses of progesterone.
Thank you for that. And this beautifully brings us to the last question in the questions and answers that, sorry, in fact, it's not the previous one, that says, what level do you consider being too much progesterone and thus deleterious for attaining pregnancy? A sort of, is there such a thing that progesterone could be toxic against a pregnancy at a certain level? Would anybody answer that to your knowledge?
To be honest, I cannot answer this question at this moment because it has not been demonstrated. And we have to be very cautious. We have to learn a lot because, as I told you, you can measure serum progesterone level 2 hours after a subcutaneous injection and see 100 nanograms. But this is not dangerous. This is normal after the injection of subcutaneous progesterone, and then the area under the cure throughout the day will be like more physiological. So it is complicated, but you will never reach supra physiological levels when using rectal or vaginal because the percentile 90 is 20 nanograms per ml. That is closer to natural. Okay.
Thank you.
The thing is that where is the critical point when using parenteral progesterone? And this should be answered. And well, I don't have the opportunity of using intramuscular progesterone, only subcutaneous. We are using this drug for a rescue treatment, but we should be cautious. I think that we are not crazy and we are not giving very, very high levels, but doses, but it has to be a further study.
Thank you. Three questions from one participant, Sergio. Two of them have been answered, but the first one not. And it's an interesting concept. What importance, if any, do you give to the relation or maybe the ratio in regard to the level of progesterone and estradiol? Is there such a thing of saying, oh, this should be the ideal ratio between estradiol and progesterone? Furthermore, many people do not even measure estradiol in frozen cycles. So,
yeah.
Are you any comments on this question?
We stopped measuring that after our studies. We were measuring estradiol in the proliferative phase, estradiol in the luteal phase, and we didn't see a correlation with the progesterone, and we also analyzed the ratio. Because honestly, I thought that I was going to find something, but not. It is true that when correlating estradiol and away pregnancy rates, it is interesting that we have seen that only in the setting of egg donation cycles, patients with higher, or no, the patients with an ongoing pregnancy had a significantly higher level of estradiol in comparison with patients with a non-ongoing pregnancy. It's the only significant finding, but not a correlation with progesterone. So
Thank
we
you.
are not using the ratio anymore.
Thank you. Very nice comments about your beautiful presentation, and a question that has been asked by two different participants. Is there a progesterone level below which you will not do a transfer?
You will cancel. Yeah.
Yes.
According to our data, no, you shouldn't cancel. We observed cases with a progesterone level of 3, in which we added rescue subcutaneous progesterone and we rescued the situation. But after analyzing so many cycles, I have realized that those patients with such a low level are not inserting well progesterone. It is very difficult to have such a low level of progesterone unless they are doing this very badly. And now we are like more intense on questioning patients. Are you doing this well? Which dose you are receiving? You spend time on asking them, and sometimes you realize that they didn't understand well the indication, and they have written indications, but they are so nervous that they do things not well. So it makes, I mean, for me, it is so important to give clear indications to the patient, and if you see something strange, just investigate on that, because it's not frequent to have such low levels.
Thank you. Patient education is crucial. Thank you for that.
Mhm.
One practical question from Bangladesh. Do you measure progesterone levels before starting the exogenous progesterone?
Always.
Okay.
Well,
So
always when we program, yeah, when we program the embryo transfer and before starting exogenous progesterone. So we always want to have levels below 1 nanogram per ml before starting the physical.
thank you. A second question, I don't know where it comes from an anonymous attendee. It says, is the subcutaneous injection water soluble? In Ireland, we have both water soluble and oil, but the oil is very painful. So what is the preparation you use in Spain?
We don't have oil progesterone. I mean, we don't have that option, so we cannot choose.
Okay.
So yeah,
It's
that's
water
why.
soluble.
Yeah. Mhm.
Water soluble. Thank you.
Mhm. But
Um,
it is true that the pharmacokinetics is different between the two of them, huh? Even
yes.
in parental, both of them.
The oil one cannot be administered subcutaneously. It has to be intramuscular, and that's why it is so painful,
Yes.
because it's slowly
Yes.
absorbed. But anything subcutaneous will be water soluble. Um,
Hmm.
One practical question again, after rescue, progesterone dose is given to the patient. When do you check the progesterone levels, if you ever check them again, in order to confirm the rescue worked or not?
We are not checking systematically once we demonstrated the effectiveness, because you shouldn't get crazy about progesterone levels. You have to see your results, your pregnancy outcome, and once after analyzing thousands of cycles, seeing that those patients with low levels and receiving the rescue treatment are having exactly the same results as those patients with good levels from the beginning, it makes no sense to monitor it so strictly, because the more you analyze, the less you understand. You have to be logical. I mean, if you are observing same results from the clinical point of view, it is not necessary unless you have very low levels, okay, and you want to check if you should give 2 injections or whatever. But we don't do it systematically because it's been proven to be effective.
Thank you. A lot has been published about the start, doses, and so on, but many people have difficulty in understanding when is it appropriate to stop the
So
progesterone. So when do you stop the progesterone? Is it the gestational age? Is it the level of progesterone? Is it immediately after positive pregnancy test? Is it later in pregnancy? What do you practice? What do you
yeah,
advise?
obviously, if you are based on literature, you could stop progesterone very early. Okay, but as I show you in the study of sub-analysis of the megaset study, it was demonstrated how those patients stopping progesterone too early in the stimulated cycles, if they had low levels of progesterone, the miscarriage rate was really, really high. So I think that we in our clinical setting we stop progesterone in natural stimulated cycles on pregnancy week 8. Once the luteal placental shift has occurred, just when the placenta starts to produce high amounts of progesterone. But in the artificial, we maintain progesterone until pregnancy week 12. Because, well, this has been demonstrated and published recently in a meta-analysis that demonstrates how in the artificial cycles there are a huge risk of spotting and bleeding. So obviously patients are scared about the risk of having a miscarriage, and at the end, I don't know if it's also a placebo effect, but finally this is important in patients with recurrent miscarriage, and when they are bleeding, obviously you are adding more progesterone. So this is why taking into consideration that in this setting patients bleed more frequently, we maintain luteal phase support until during the first trimester of pregnancy.
Thank you. Very clear. I was particularly impressed with your last slide, which clearly summarizes beautifully the uniqueness of the artificial cycle and also the pure natural. So wondering maybe in the future we should just recommend modified natural cycle and of course the stimulated cycles and try to avoid the situation of pure natural and artificial. Would you give us some comments? Because that's the only scenario when we should measure the progesterone. The other ones, we can just rescue the luteal phase nicely and prevent this drop in progesterone. So any comments on that?
Well, for me, I mean, after all our research on artificial cycle that has been very, very extensive, and being aware in the last years of the risk associated with the artificial, I think that we have to do things well to protect the patients, to give, because I have realized that we can save the situation, rescue the treatment, the luteal phase support, but how much hormones the patients are receiving. And when you go to to modify natural, you see that with much lower doses of progesterone, the patient is being exposed to double the levels of progesterone. So we need to be like more logical, and if it is possible to move to natural, but logistically, and mainly big centers like ours, we cannot do pure natural so easily. It can be done, okay, but fortunately the option of the modified natural cycle is very good because it allows you to schedule the day of retransfer in the context of a natural cycle. In fact, our colleagues from EB Madrid demonstrated how the results are comparable no matter the size of the dominant follicle once the endometrium is ready. So this is very good news. And if you give exogenous progesterone, you cover most all patients. So I think that this could be probably the most ideal scenario in the future. But we will continue doing artificial cycles for sure, but doing this well. I mean, if you individualize, that's okay, but if you give too much progesterone to everyone, too much estrogens, I think this is not a good practice.
Professor Labarta, I'm aware that you've been giving us 80 minutes of your precious time. I'm aware you're in the middle of a working day, so there are no more questions as far as I see. The last question was if your presentation will be available, and I've already placed a message in the chat saying that this presentation and all previous presentations related to progesterone use in human reproduction are available on the IFFS website at iffsreproduction.org, education, under archived activities. So I'd like to conclude, unless there's anything else. I see a final question here. Up to what age do you do natural modified cycle transfers? Up to what age? Do you have an age limit for the female?
Yes, for doing cycles, we put the limit on 50 years. Obviously, most of those patients are doing oocyte donation treatments, and if you have to do an embryo transfer in a natural cycle, you need to have regular menstrual cycles. If not, so the limit is not the age, is the availability of generating an spontaneous follicle. And if it is possible, it is the ideal protocol to prevent from preeclampsia, mainly in these patients who are older. But not always it's not always possible. If you have to go to an artificial at this age, it is recommended to give aspirin in order to prevent from that risk.
Thank you so much. With that, I'd like to, as I mentioned, say thank you to you, Professor Labarta, and also to thank the large audience for attending today, and reinforce the fact that this presentation will be available on the IFFS website in the future. So thank you again to everybody, and look forward to seeing you for our next IFFS webinar in a month's time. Thank you, Professor Labarta. Have a nice afternoon.
Thank you so much to all of you. Thank you. Bye.